So AGILE is a phase III randomized global study of ivosidenib and azacitidine compared to azacitidine and placebo in older patients with acute myeloid leukemia who are unfit to receive intensive chemotherapy and who harbor IDH1 mutation. The primary endpoint of this trial was event-free survival, and the secondary endpoints were overall survival as well as remission rates. So this study was conducted in about 20 countries globally, and patients received 1-to-1 randomization between ivosidenib and azacitidine compared to azacitidine and placebo. Demographics-wise, there were in total 146 patients were randomized in the study, around 72 patients in the ivosidenib-azacitidine arm and 74 patients in the azacitidine arm. So they were well-balanced group between both arms. So about 75% of patients were de novo AML, and 96% of patients in the ivoAza arm had intermediate or adverse risk genetics. So at a median follow-up of 12.4 months, event-free survival was significantly longer in patients treated with ivosidenib and azacitidine arm, which was 22.9 months compared to 4.1 months. And the probability of patients remaining event-free at 1 year was 37% in patients treated with ivoAza arm compared to 20% in the azacitidine group. And we've also noted a superior overall survival in patients treated with ivoAza arm, which was 24 months compared to 7.1 months. In addition, remission rates were also higher. It was nearly threefold higher in patients treated with ivoAza arm with a CR rate of 46.2% compared to 14.9%. In terms of going on to the count recovery, there was an improved and a quicker neutrophil count recovery was noted in patients treated with ivoAza arm. And in fact, neutrophil count went up from 0.99 to 2 as early as week 2. And this continued to increase for up until 5 weeks before it stabilized, compared to patients treated with azacitidine arm, where there was a gradual continued decline in the neutrophil count up until 36 weeks when it started to return to baseline. Transfusion independence was also superior in patients treated with the ivoAza arm. This was nearly 46% of transfusion independence in patients treated with ivoAza arm compared to 17.5% in the patients treated with azacitidine arm. So we also collected quality of life data in the trial, and we used this using ERTQL QC30 questionnaires. So quality of life studies also showed after an initial drop in quality of life in both the groups for the first 4 months. Following this, there was a continued and sustained improvement of quality of life in patients treated with ivoAza arm in both the function domain as well as symptom domain. This remained superior to patient treated with azacitidine. Toxicity profile was very similar. There was no significant increase in toxicities, but neutropenic infections were less. It was only 28.2% compared to 49.3% in azacitidine arm. Adverse events of special interest with the ivosidenib is differentiation syndrome, which was seen in about 14% of patients, as well as QTc prolongation, which was seen in about 9% of patients. Differentiation syndrome was well managed with count reduction using cytoreductive treatment, dexamethasone, and temporary interruption of the medication when needed. No patient stopped treatment because of the adverse event of special interest, and there were no deaths due to adverse events in patients treated with ivoAza arm. So just to summarize, this was a phase III study looking at ivosidenib-azacitidine versus azacitidine in older AML patients harboring IDH1 mutation who were not fit to have intensive chemotherapy. So we showed that the treatment with ivosidenib-azacitidine gave a superior event-free survival, overall survival, and remission rate compared to azacitidine on its own. Toxicity profile was similar. There were less neutropenic infections, and there were no toxicity-related deaths. In addition to that, quality of life was also superior in patients treated with ivosidenib and azacitidine.